Good afternoon. Today is August 26th, Friday. This is United Medical TV, UMAC TV from United Medical ACO. We have our regular weekly updates. Today, we have a small change. So Sean is off and Donna is with me. Donna Gankul, she's one of our directors. Donna, how are you doing?
Doing very well today, Kemal. How are you?
Good. So we are going to have our COVID updates. And we are going to have Dr. Dhruv Patel from Kidney Care Associate joining us. And we are going to discuss chronic kidney disease as well as known as the CKD and also dialysis. And Donna, we are going to start with the COVID update from your side.
All right. Thank you. So I just wanted to give a quick overview of the current COVID updates. So as of yesterday in the US, we have just under 96 million total cases since the start of the pandemic. As of yesterday, we are now seeing in the US, it was just under 60,000 daily cases. So we are starting to still see a decrease in the number of cases on a daily basis. Some countries, such as South Korea, is still seeing over 100,000. Yesterday, they had 113,000 new cases. And in Japan, they had 237,000 new cases. So overall, we can see that there have been 603 million cases. There have been over 6.4 million deaths and 578,000 who have recovered. And again, those updates are as of yesterday. I'm going to skip through some, Kemal, just because of the graphs, but I will go to the vaccinations. So the Delaware vaccinations, there are fully vaccinated 600, it says, and 26,000 people. 49,000, I guess just under 50,000 have had at least one dose, which is good. So we want to continue to see, and especially with schools starting, that individuals are continuing to get their boosters.
Now, in terms of the maybe monkeypox updates, if you can just go through that real quickly.
Sure. Let me just jump down there real quick. So when I pulled up the information, it looks like, so this was as of August 24th. So we are still seeing somewhat of a spike from not yesterday, but the two prior days. We're still seeing over, it looks like over 600 cases per day. But again, that is throughout all countries, not just the US. So, and it looks like the average 7-day cases were slightly going down. We saw a small spike, but now it looks like it is starting to trend downward as well.
And in terms of the treatment, there's still no clear treatment options available.
Correct. Nothing new on that front.
All right. So, and then after maybe we discuss the CKD and the dialysis with Dr. Patel, we can actually maybe come back to some of these issues. So I'm going to actually let him in. Dr. Patel, how are you doing?
Good, Kemal. How are you doing?
Good. Well, thank you for joining us. So before we actually start, if you can introduce yourself. I know this is your second time with us on this session. So then there are some people who may not actually know you.
Hello, everyone. I'm Dr. Dhruv Patel. I'm one of the nephrologists in Delaware. I'm a part of a Kidney Care Associates, and we are a team of two doctors, Dr. Ramil Patel and myself, Dr. Dhruval Patel. And we have been in Delaware for almost 10 years and serving the local population. We have two offices. One is Newark office that is near Christiana Mall, and second is on Gilpin Avenue near Gilpin Hall in the Wilmington city. And we served majority of the hospitals in Newcastle County, including Christiana, Wilmington, St. Francis, and we also provide the inpatient care to Kent Dover Hospital.
Well, thank you. Dr. Ramil Patel actually joined us, I believe, a month ago, or maybe a little more than a month ago. We went through some of the kidney-related issues with him. So we are going to discuss the, as we day-to-day we call it CKD, but it's chronic kidney disease, and also the dialysis. So again, with these, just to kind of give the background on these two issues to disease, and then we have some questions, Don and I, so then we can actually continue with that.
Sure, Kemal. So let me first explain that why it's important to know about the chronic kidney disease. First, what is chronic kidney disease? Chronic means long duration. Kidney disease means disease of the kidneys. When we say it's chronic, we define 3 months. If your kidneys function is not normal or suboptimal for more than 3 months, we say that you have chronic kidney disease. But why it's important to know about the chronic kidney disease? The main concerns is that it's a silent problem. Only way to detect the kidney disease is by blood work and the urine test, because the symptoms or having the problem from the kidney disease does not become prominent till your kidney function drops below 10% or so. And if you look why it's more important in terms of the Medicare population, is that right now, almost like 37 million patients suffer from the chronic kidney disease in the United States. Almost like 725,000 patients are on dialysis, what we call end-stage renal disease. When your kidney function doesn't work, you need dialysis to clean your blood and remove the toxins. And if we look at the expenditure, like Medicare is spending 7% of the Medicare budget is allocated to kidney disease population, and that only consists of 1% of the Medicare participants. So it's a huge burden as a society, as a community, when it comes to the financial burden of the kidney disease. And 1 out of 5 patients who start dialysis unfortunately die within 1 year. So that it's kind of a heavy toll in terms of the mortality when patients end up with the dialysis when the chronic kidney disease progresses. So chronic, yeah. Right, so main cause of the chronic kidney disease is diabetes, and second common cause is blood pressure. So we're gonna more focus on the diabetes and the blood pressure. So as I said, that it's a silent problem. So when by the time your diabetes, so there are 2 types of diabetes, type 1 and type 2. So typically we recommend screening for the kidney disease when you have type 2 diabetes at the time of diagnosis, because we presume that that has been happening, kidney disease, for a while, because type 2 diabetes is when discovered, there may be some element of the kidney disease in majority of the patients. So they should be screened at the time of diagnosis when they are type 2. But when it comes to type 1, typically we wait for 5 years after the diagnosis of type 1, just because they are the patients who have early recognition of type 1 diabetes. So typically your primary care provider does the urine test and some blood work, what we call urine protein test, that would detect the kidney disease in an early phase.
So in terms of our patients, so, you know, from at least from my personal level, and Donna, she's a trained nurse and I'm not, so, and because I'm not also a clinician, but we are in the clinical world. So one thing that actually became very clear to us is, especially when we start doing our case conferences, we realized that actually, in many cases, CKD is not being diagnosed right away. And the reason we are saying this is because we actually, with our nursing team, we go through these every day. We actually go through the entire chart, look in the blood work, look into the other parts of the chart to understand if there are any other issues that patient may have. So, and then what we have seen is, I think the GFR is one of the least, maybe if the patient is not complaining, it seems like we are really not looking into that, right? So from the primary care standpoint, we do want to actually point out that we really have to look at the entire lab results altogether. Even if the patient doesn't have complaints, there may be underlying issues that patient may not know. So we are helping with those early diagnosing part, hopefully. But once the patient is, I think what I would like to know is that once patient is with the nephrologist, what changes? If someone has, let's say, GFR 44, that would be like 3B, right?
Yep.
See, like this is what we learn every day now, like conference. So, and that's the right on the border. If it's 45, it's going to be 3A. So, what it means for us, for the patient, but also what it means to you from a nephrologist standpoint. So, what treatment options that patient may have? Can it be actually cured, or can it be controlled? So, we are always looking at the prevention and then trying to educate our patients on prevention. So what treatment options they have, but more from the nephrologist standpoint.
Yeah. So thanks for pointing out that, Kemal. So as you said that, it's a silent problem when the primary care screen the patients, typically, GFR is more important than the creatinine because creatinine have more variables. Like 90-year-old grandma can have normal creatinine, but she's probably in stage 3 just because her muscle mass is lower. So GFR is more reliable test, and obviously urine protein is also more indicator of the having kidney disease. So stage 3, most of the time GFR they reports less than 60. That's when GFR they report most of the labs as a highlighter. So that's when I think it catches the eye, whether it's primary care provider or whether it's patients or the family, and that's already in stage 3. So typically when a nephrologist sees the patient, most of them end up on stage 3. So stage 3 for our community, just stage 3 is between the 30 to 60% kidney function falls in stage 3. And now we have divided between 3 A and B, when 15 to 30% is 3B, and 31 to 60 is stage 3A. And stage 4 is when GFR drops below 30%. But typically when we see the patient with stage 3, stage 4 kidney disease, it's a collaboration between it's a multidisciplinary approach when it comes with the primary care provider, patient, and family. Because the goal here is to, number one, is slow down the kidney disease. First is identify the kidney disease, because the majority of the time is diabetes and high blood pressure. But sometimes if they have some blood in the urine, then we end up doing the kidney biopsy, that is more diagnostic test, to see is there anything else going on besides diabetes and blood pressure. Sometimes there are some rare disease like inflammation in the kidney disease. Sometimes some toxic medication like Aleve, Advil, ibuprofen, some what we call non-steroidal over-the-counter anti-inflammatory drugs has caused the problem. And we detect the problem early. We stop the NSAIDs. If there is some allergic reaction from the medication, we treat with the steroids. So it depends on what we find. But let's say if they have diabetes, which is more common, and the blood pressure-induced kidney disease, which is more common. So first is tight blood pressure control. And as a nephrologist, we have a little bit, especially when the patient with kidney disease, we have more multi-system approach to control their blood pressure with the diet and diet modification, lifestyle modification, and obviously medication adjustment. Second is that we also look at their labs, see how's their potassium. We counsel them about the diet, what to do to control the potassium if it's higher. Third, we also look at their acid level in the blood. If their acid level is building up, there are many studies that we treat them with a pill called sodium bicarbonate to slow down the acid building up, which has been shown to slow down the kidney disease. If their uric acid level is high, we try to control that with medication and low purine diet. And also when the chronic kidney disease comes with a combination, it also causes anemia. So if patient has anemia with advanced kidney disease, we prescribed a medication called Proporate or Epogen to keep their blood count at a certain level between hemoglobin between 9 to 11. Kidney disease also comes with bones disease. Their bones becomes weak. So we check their calcium level, their vitamin D levels, and we treat that part to keep their bones healthy. So it's basically, there are many multi-modal approach to slow down their kidney disease. Now, diabetes in last 1 year, there have been more and more studies done and new medication came in the market like Farxiga, Jardiance, Kerendia. Those are all other new medication has been in the market to slow down the kidney disease. It slows down the protein in the urine too. So basically it's all about risk modification, so that our goal is to keep them in stage 3 for a long time before 3 goes to 4 and 4 goes to 5. Now, when they reach stage 5 or stage 4, despite of all, our goal is to choosing the patient and the family, preparing them physically and mentally for the next step, meaning the dialysis or the kidney transplant, if they are a candidate for the kidney transplant. Right, education about what kind of dialysis would be appropriate for them down the road, so that they can choose the best modality that would work better for their lifestyle and patient and the family.
So I'm going to actually bring one image outside of our video. Mm-hmm. So Sean Donegan, you know him from our business development, who normally helps me with these. And so 2 weeks ago, I said, Sean, I need a couple images of these comorbidities who are, like, I used to call them evil sisters. So then my sisters got offended by that. So, but I think this image that we are working on, we are not done yet. Okay, so Sean hopefully is watching, and hopefully he's not upset that I'm sharing this a little bit early. These 5 problems, in many cases, in this case, like the hypertension, diabetes, and congestive heart failure, and CKD, they are together in most cases. So that's what we have been seeing. Like maybe COPD is not that much. I don't know, maybe at least that's not what we see. But when I say these are the like the evil sisters, the idea is we never have any of these chronic issues by themselves. We always have them with one of these guys altogether. So this makes it a lot complicated from the treatment side. And then I think one of the things that we are trying to also change the PCP approach. So, and when I say this, I'm being careful with what I say. I'm not saying that PCPs don't actually don't know how to treat these. Of course, they are able to manage. But then when patients are already dealing with multiple problems altogether, the best option is to bring the specialist on board. But bring the specialist early on so that it's not too complicated with these problems. So I think that's where we need to, I feel like we can improve that more because that early intervention is the most efficient. Actually, the change on the outcome is coming from that early intervention with these problems. So when you work with the other specialists, just to give us a little bit background on that, how do you guys work together with the PCP and other specialists that you work with?
Right. So basically, as you pointed out, the cardiovascular disease is #1 cause of the mortality, even in the end-stage renal disease patient. And that goes without saying when the cardiovascular mortalities, whether it's coronary artery disease, whether it's congestive heart failure, whether it's cerebrovascular accident, meaning stroke, or whether they have a problem with the peripheral artery disease, whether they have some blockage in the blood vessels of the heart or the legs, that all comes, especially it's a high risk for chronic kidney disease patient, because their phosphorus is high, their calcium metabolism gets abnormal. Blood pressure is very difficult to control when they have advanced kidney disease. So that comes as a combo, and multidisciplinary approach is helpful. So basically what is important is that, let's say, just give you one example. If patient has abnormal stress test at primary care provider's office, so typically cardiologists do recommend getting the cardiac catheterization earlier to see what kind of blood vessels is blocked and what can they do to unblock it. Now, problem with that patient with the chronic kidney disease, they typically don't want to give the dye, the contrast, where they have to inject the dye to see which blood vessels are blocked. Now, this is where the multidisciplinary approach, whether it's the contact between the cardiology, primary care, and nephrology, is of vital importance, because we have to give them medication before, like hydrating the kidneys, so that the dye would not cause the problem to the kidneys. So having same EMR, or even like sharing the system, whether we are part of the ACO, that's also helpful, because it just takes one message, the primary care provider and the cardiology, and I think it's better communication and better outcome for the patients, and we make it happen with less risk to the kidneys.
Yeah, I think you actually you went ahead, but I was about to just point out our logical domain, and I think some patients are watching these, and it would be a good education for them as well. So United Medical ACO is designed under a logical domain term that allows us to share the patient's chart by multiple providers who are part of our system. So when we have to work with different clinical issues with different specialties, the tool becomes extremely important. Well, in this case, EMR is the vehicle, is the tool, and if that's available, and then if the providers don't have to go from one to the other, and if they can find everything in one chart, then the efficiency and not missing something, or asking patients to bring records, those are all kind of eliminated. So we try to design this in a way that the multidisciplinary approach can be supported by our IT design. And I think that's where we are right now. And then actually we just got our ACO results that I'm not legally able to share yet. So, but we have good news from different programs that we have. Well, I mean, we are able to share the Blue Cross and the health options, but there's some others coming up. I believe we'll make them public hopefully in the next couple of weeks. So this really helps. And then as you were explaining, when you are working with the other specialists, for you guys to be able to seamlessly work in the same system, that actually makes the most impact also on the clinical outcome, because you don't miss anything. And also we have our nursing team. So right now, every week we go through about like 40 new patients just for the case conference purpose. Our nurses, they are nonstop reviewing these patients. Now, while we are trying to help the patients, and in some cases, when the patient's chronic kidney level goes up, then it's in some cases it's inevitable for them to go to dialysis. Now, and being in the nephrology specialty for a long time, myself from the business and clinical side, I know we used to be focusing on the dialysis centers a lot, but then there are other options now available, and they're more maybe practical for the patient purpose, referring to the home dialysis perhaps. So can you talk us about the transition of CKD becoming the dialysis, and then what options that we have on the dialysis side?
Right. So when CKD continues to progress, typically patient does not need what we call renal replacement therapy, meaning dialysis, till the GFR drops below 10%. Exceptions are the diabetic patients, because sometimes, or the congestive heart failure patients, where they have problem managing the fluid because they retain the fluid and we have to start dialysis a bit early. So the dialysis is indicated when the fluid management becomes difficult with the help of water pill, the diuretics, when kidney disease continues to advance. And some of the electrolytes, if the potassium goes up or if the acid level builds up in the body, those are other indications to start dialysis. And third is that if they feel poorly, their appetite goes down, they have like swelling, they are confused, meaning the toxins are building up in the body, and these are the times to start dialysis. Now, there are many studies done that if patients are being followed by nephrology from CKD stage 4, there are more likelihood that they will end up with what they call fistula when patient goes for the in-center dialysis, what we call hemodialysis, meaning cleaning the blood with the machine where they put the needles in what they call fistula. That means it's a connection between the artery and the vein in arm. They put the 2 needles, one to take the blood away from the body, cleans the blood, and it will be returned to the body from the other needle. So that is more safer way to getting dialysis through the fistula. If you wait too long, then patient will end up with the port in the chest, which has its own risk of infection to the heart, and so on and so forth, getting the poor clearance. But what we recommend in our practice, and I'm sure nowadays it's more popular, and also outcomes are a little bit better when it comes to the peritoneal dialysis, meaning that patient do dialysis at home, at the comfort level of their home. Typically, they do it at night. So we do refer patients to start getting the dialysis modality education early, so they know that which modality is safer for them and convenient for them. So in peritoneal dialysis, typically patients and the family attends the education sessions, and we refer them to the surgeon who can put a tube called a catheter in the abdomen. So basically your abdominal membrane called peritoneal membrane work as a filter, kidney filter. And there are bags of the fluid from that tube goes in the abdomen. It sits there for 2-3 hours, whatever we prescribed. And it takes out the toxins and then drains out in the drains. So basically that's what we call peritoneal dialysis. It's more convenient. It's less, overall it's less stress for the heart because you are doing dialysis every night. So more patients with the coronary artery disease, congestive heart failure, or some valvular heart disease, if they're aortic stenosis, those patients do well on PD, peritoneal dialysis. And now the techniques is so evolutionized significantly that like they have what we call ambulatory CAPD machine. So it's called a cycler machine. So basically it's a software, a very portable machine comes at night, and whatever you plug in the numbers, let's say 5 cycles, 2 liters, or 6 cycles, 2 liters, or 4 cycles, you hook yourself to that tube and unhook in the morning. And depending on what numbers we plug it in, that machine does everything for you. In the morning, you wake up, you unhook yourself from that tube, what we call PD catheter, and you're good to go. So I have a few patients, interestingly, I would share, I have one patient who was truck driver, and he drives the truck, and unbelievably, he drives the truck and also doing the dialysis at the same time. Obviously, most of the time we do not recommend that because it has good action, but he chose to do so. And just it gives more flexibility to like even lifestyle, more independence. You don't have to go to the center 3 times a week, because in hemodialysis, it's 4 hours 3 times a week. You will be assigned whether it's Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. And you have to go 4 hours 3 times a week. One session lasts for 4 hours. So it's more transportation issue, a weather issue, which is not more kind of logistic issues are not problematic when it comes to the home dialysis.
I see. And I think that's a lot more convenient for those patients, again, for several different reasons. Now, did I hear that right? That this is done, home dialysis actually is improving more and more.
Right. So I think in last 10 years, I think when you look at the data, I would say probably initially there were only 4% of the patient were starting with this dialysis. Nowadays, I think it's gone up to like 8%. And the way I think the techniques, because even patients who are blind, they have the software who speaks, who gives the instructions. And so that even because, blindness is also common in diabetic kidney disease patients. So it's very helpful to do dialysis by just listening to the instructions. even if your eyesight is weak. So basically, I think it's overall, it's more flexibility, more control to the patients and the family. And they come to see the doctor in the center only once a month. We go through the labs and discuss the labs and see what needs to be changed and so on and so forth.
See. So
go ahead.
I was just going to say, Donna, you are very good.
I do have one question because as Kemal mentioned, as we go through our case conferences, we see, and not just with patients who potentially are getting to that point of having chronic kidney disease, but we see a lot of non-compliance with taking medications. So we've gotten to the point now, in addition to looking at labs, we're also looking at medications. When's the last fill date? Who's giving it? Specialist versus PCP. Again, trying to manage that patient with multi-specialties. But one of the things is sometimes getting the patient to go to the appointment, even with a PCP, or compliance with lab work. But I think a lot of times what we hear is the patients are saying, yes, I have diabetes. I may have high A1C, right? My A1C may be 9, 10, 12. I may have hypertension. We see some very high blood pressures. We had one this morning where the patient's blood pressure was, I think it was like 190 over 100. But we have patients who say, but I don't feel bad. So I don't feel like I need to go see the nephrologist, the cardiologist. So what piece of advice, I guess, would you give to a patient here, right, that might be listening, to encourage them to come before they have the symptoms, right, before they feel bad?
Right. So Dana, thanks for pointing that out, because, again, I don't want to scare the patients, but what I have seen is that, because again, blood pressure, it's caused the end organ damage, right? Whether it's a heart failure, whether it's a coronary disease, whether it's stroke or the kidney failure. So the problem happens when the symptoms of the elevated blood pressure are not being treated or not being ignored. Because we have patients who have high blood pressure for a number of years, 40 plus years, with normal kidney function, normal heart, normal brain. And we have patients who did not take care of the blood pressure for whatever the reason may be, whether it's a psychosocial problem or just a personal preference, whatever the reason may be, those are the patients with high risk. So what I would say is that typically, if I'm the patient, what I would look is that whether I really want to have the stroke, whether I really want to have comorbidities, whether it's the heart attack or the kidney failure, end up on dialysis, because blood pressure, diabetes, early detection, early cure, early treatment is very important, because it's a silent problem. When your primary doctor asks you to see the subspecialty or even they recommend medication, I highly encourage to stick to the medication plan, remain compliant with the medication, diet, because you can ignore it for a while, but it will catch up, and what we pay a price, it's not worth it.
Thank you. And that's kind of what our nurses and our care coordinators and everyone is trying to help from an education perspective, right? Is prevention, right? An ounce of prevention. Because again, to your point, we don't want to scare people, but at the same time, we want them to see the big picture and not just the moment, not just the today, but what could happen 1 month down the road, 1 year down the road, 10 years down the road.
Absolutely.
Well, I think the other thing is that maybe a little bit being scared is fine, Donna, because I think most of our patients in the CKD dialysis world are elderlies. So, and I think as they are aging, they don't listen as much. And I know you are dealing with one, and I'm dealing with two. So just, since my dad doesn't speak English, so I can kind of bash him. So this hypertension medication without telling anyone, because he was, as to your point, he was feeling just fine.
Mm-hmm.
He said, oh, it's well controlled. I'm like, it's well controlled because you were taking your medication. Now it's off the roof again, and now he's panicking. So there's this, I think these chronic problems, what our patients don't understand in some cases is when it's stabilized with the treatment and the management, that doesn't mean that you stop those treatment because it's not cured. That's why we call it chronic problems. So it's being managed, not being cured. So that's kind of maybe the difference. And I see this time to time with my family members. So it's not the first time one of the family members just stopped on their own their chronic care medication. So I guess a little bit, scaring them a little bit is for their own good, at least in my opinion. Now, Dr. Patel, I know we are taking time away from your patient hours, but I have one last question. I know we focus on the elderly because almost 75 to 80% of our patients are Medicare patients, but there are also patients who are a lot younger, but they don't actually know. They may be experiencing CKD issues in the near future if they are not stopping certain things. Like this is their eating habits with a lot like high protein, and in some cases you just mentioned taking unnecessary painkillers like Advil, ibuprofen. Do you see those patients more these days than before, or is it just like the same? Like what's happening with the younger population with CKD?
So I think in general, the number of the diabetes, number of the obesity is also one of the risk factor. So the more the patients with obesity, diabetes, high blood pressure at a younger age, and now we are living in this drive-through lifestyle, right, where everything is not physically that active. So that catches up, whether it's blood pressure or diabetes or obesity. So even the young patients we are seeing more young patients with kidney disease. And it's one good thing that maybe we are recognizing or we are detecting or diagnosing the problem at a younger age. Now that if you are more compliant with the primary care, they will be doing your blood work and the urine test annual every year. So those patients are referred to us when they have some protein in the urine or blood in the urine or some abnormality in the GFR. Yes, I think overall, because of the high unhealthier lifestyle, whether it's a more high carb diet or sedentary lifestyles, that all or obesity creates more risk factors for the kidney disease.
Well, one of my really good friends, he's a nephrologist, Dr. Enver Akalan. So he's well known, not just in the US, but I think worldwide. So I'm always kind of like proud of him. So I talk about him all the time. But he's the one who actually just warned me like several years ago, because I used to take Advil all the time after playing tennis or after working out. And then when he found out how many I was taking, he panicked. He's like, "You're going to lose your kidney." And I'm like, well, no one knew that. So even now, like when we talk to people, they don't. I think we want our younger population to also pay attention to this. And actually, what you just said, all the other issues are increasing. Therefore, it is inevitable for this part of the problem to go up as well. Well, Dr. Patel, again, thank you so much for taking time away from the office hours and being available for us, being available for our patients. You and Dr. Rami Patel, you guys make a big difference in our patient population. And we thank you for everything that you do for us.
Well, thank you. Thank you for having us. Thanks.
Right. Thank you. All right. So, Donna, we are almost at the end of our, let's see where we are. So I'm not going to get you in trouble with Biden or Trump. So then you are. Well, did you like these pictures?
I do. Yes.
So,
I think they help get the point across. And the one thing I did want to say, not necessarily with Dr. Patel, but just for our patients out there. So we also, when our nurses are working on the cases, because they are your care manager, so they are sending emails out to patients and portal messages. So we do encourage the use of our patient portal. You're able to request appointments, request your medication refills, so you don't have to sit on hold or try to contact the office during certain hours. You can do that at any point. But we also communicate with you that way to send you patient education, to send you emails about things to remind you of things such as your, blood work that's overdue, needing your annual physical, needing to get the appointment scheduled with your nephrologist, your cardiologist, especially if you haven't been for a while and you are seeing them, or if you have a new referral to go see that provider. So we're there to help guide you through that process.
So that's our part of our case conference, and this is one of the old videos that I'm playing right now. But our goal is to reach out to more patients if we are able to get them in different ways, because these when we send something from our EMR portal, it becomes like a just generic email. So they have to open the portal, and sometimes that we all get lazy, I guess. So we try to actually increase the efficiency of the communication that you are getting directly from us. So then the subject line just tells you that you missed your PCP appointment and you need to call them, or it tells you that you need to do your blood work. I mean, you can read the email and it will give you the instructions of other things that you may have, or signing up for our diabetes classes, support groups, and all the other initiatives that we have. So, but we want our patients to be actively involved in their care, and we can hopefully improve what we do for them.
And improve their outcomes, right? So that they don't get to those points at the end with needing dialysis and, many other things, because we've helped them with prevention and staying on track. And to Kemal's point, we do have our own internal dietitians who can help you with your diet regimen, regardless of whether you're looking for weight management, you have high cholesterol, high blood pressure, diabetes. So we do have a lot of things that we can offer internally within the ACO.
So in 13 minutes, we are going to continue the journey with these three individuals on Bariatric Friday. Dr. Erkan will be joining me, and then we are going to discuss the multivitamin deficiency during the bariatric process. Hopefully you guys will be able to join us, and we'll see you. Actually, we are going to take a 2-week break, so I'll be in Turkey. So then we're going to start our weekly events. I think it's the second week of, after the second week of September.
So next Friday's the 2nd, then the 9th, so you'll resume on the 16th?
Sure. And then we have new speakers signing up, confirmed. Lieutenant Governor Bethany Hall is going to be with us in October first week. And then we are trying to sign up for other state officials. Hopefully we'll have a lot of new speakers, and then we'll be discussing other issues with you guys. Well, until the next time, please be safe, and then we'll see you soon.
Thank you.